Hey everybody, let's talk about lumbar fusion. So this really is kind of a continuation of the two recordings that we did for a lumbar microdiscectomy or a discectomy with laminectomy. So we've got those, and there was a lot of background during those presentations related to lumbar vertebrae and lumbar disc anatomy. So we're not going to go over those in this lecture. But we are going to review what we talked about related to when surgery is appropriate. And you'll notice that a lot of the same types of injuries and the same types of patients that a doctor might choose to do a microdiscectomy, if the symptoms are bad enough, they may actually choose to do a fusion. So a lot of those patient populations might be very similar in terms of what you're expecting to see afterwards. But I would say that fusions are going to happen with your older population who probably are having a little bit more complications related to things like stenosis. So, as we all know, lots of people have low back pain. And most of the surgeries, as I just said, are going to happen for fusion for patients over the age of 65. And stenosis tends to be the most common diagnosis that leads to a fusion versus possibly more disc pathology being what leads to a microdiscectomy. The hard part with fusions is exactly what it sounds like. A fusion literally means that we are putting two vertebrae into the same movement pattern, into the same plane. So not allowing those vertebrae to move individually, but move together. And if the fusion is more than two vertebrae, 3 or 4 vertebrae, then that means all of those vertebrae are basically stuck together without movement. And so unfortunately, this can lead to complications for many, many reasons. And a lot of these people need a second surgery within the first 2 years. So if you can see from the statistics, 1/3 of your patients who have a fusion may end up having some other surgery very soon afterwards because we've lost complete mobility of the lumbar spine or partial mobility of the lumbar spine. And we'll talk about those complications a little bit later. So again, this is kind of review. This looks like the slide that we saw when we talked about a lumbar discectomy. Disc herniations are one possible reason that a fusion might occur, especially if it's a really bad herniation. And so we know that disc herniations happen usually with some sort of bending, lifting combination, or bending and twisting combination, or a combination of all three. Also, sometimes in sports-related activities, we could end up with a disc herniation. And it can lead to 2 different presentations of symptoms. If the disc herniates and only applies pressure to the outside or irritability to the outside of the disc, then we tend to have what's called referred pain. And so that's pain that's coming from tissue around the disc, but is referring into the lower extremity. And that is different than what's called radiating pain. And radiating pain means that there's literally some sort of tissue from the disc that's actually pressing on either the central spinal cord or the nerve root. And in that case, we have radiating pain, which is more of a nerve type of pain. Usually with non-radiating pain or degenerative disc disease, disc bulging, it's unlikely that they will choose to do surgery. But if it's a bad enough radiating pain where there's a lot of nerve problems, then we're more likely to do surgery. Spinal stenosis also provides some sort of issue at the central spinal cord or nerve root. And what happens in the case of stenosis is that we end up with some sort of narrowing from extra bony growth or from just a change in the bony, the area basically of the vertebrae around the nerves. So this can happen because of the vertebrae themselves or possibly a disc and a disc herniation of some kind. It's pretty common, and we talked about how in the last presentation about how there's a lot of people, if you were to look at their MRIs, maybe half of the people at mid-age will have something going on like this with their discs, but no symptoms, so we don't worry about it. But those people who are demonstrating symptoms as well as stenosis or a significant disc herniation, those are the people that we're thinking about treating in some way. And if it's very, very bad, especially if the stenosis is causing some problem to the central foramen, Then they're going to demonstrate changes in gait. They're going to use a wider based gait to help with balance and control. They may report histories of what are called drop attacks or falling. And they're going to have more pain with things like extension. And so that extension, again, is going to cause more closing of nerve roots. And so they're going to report more pain. They may have more other symptoms like myotomal or dermatomal weaknesses, or dermatomal changes, myotomal weaknesses. So we're diagnosing these, again, very similarly to what we saw with our last presentation. With a disc herniation, you need an MRI to show the soft tissue. But with stenosis, you can usually use an X-ray. They might also do a CT scan or an MRI, again, to see if there are issues specifically at the nerve root level. On the left, we have a CT scan in this picture, and on the right, we have an MRI. And they're showing you sort of where that disc is affecting the spinal cord. So these people can't have non-operative treatment. We spent a lot of time talking about non-operative treatment with the previous presentation. So I'm not going to go into a lot of detail here, but these are the patients that if we're seeing them non-operatively, we're following either a referred pain or a radiating pain pattern for treatment. So that's in the clinical practice guidelines that we refer to throughout these presentations. Those guidelines are part of the Journal of Orthopedic and Sports Physical Therapy. A lot of these patients, once the referred pain or radiating pain is decreased, they may be presenting with the movement coordination pattern. So you're spending time working on teaching them how to control and improve movement quality. So after you've fixed the issues related to nerve pain or referred pain, you're moving on to helping them improve their movement patterns. For this group, again, the fusion is going to occur with patients who have much more significant symptoms, or they're older patients with more central spinal cord issues. Spondylolisthesis, or any type of significant stenosis where multiple nerve roots are involved, will almost always lead to surgery. If they just have spondylosis but no other symptoms, then they're probably not going to have surgery. I see surgery for fusions done in China more than in the US at this time, but I would say 20 years ago, fusions were done a lot more frequently in the US. So I don't know if the trend is going to change in China as well, but I think the doctors and surgeons are really trying to find ways to decrease the likelihood of requiring a fusion surgery because, again, the complications tend to be more significant. There's inconsistent rates of success for fusion versus conservative treatment. And so there's definitely a lot of surgeons who are choosing to try conservative treatment first before they're doing a surgery. But if there's issues with more than one nerve root, and there's myotomal or dermatomal weakness, dermatomal changes that are significant and affecting their daily lives, then that's definitely situations where they may consider surgery. And then we talked about spina equina in the last presentation, and that's definitely a situation where we would consider surgery. So that's where they have that impaired bowel or bladder functioning and decreased sensation around the area that we go to the bathroom. So there's several different techniques that you will come across, and I've come across these different techniques in China. There is a posterior approach that still, I would say, is the most common approach, but there's also what's called an anterior approach, and then there's a combined approach where they do both. And I haven't really seen the combined approach, but I definitely have seen the posterior approach as well as the anterior approach. We are going to see a video for this one, so we'll show that in just a second, but just to keep in mind, posterior approach, most common, they have to move the erector spinae out of the way, and then they do a laminectomy. So they usually will they'll cut through the lamina and then fuse the two bones together using screws and a rod. And then oftentimes, if the disc is really messed up, they'll actually do a bone graft where the disc used to be. So they're going to use an allograft of bone, which means that they're using some sort of cadaver bone. In China, that's done a little bit differently, because again, we talked about how people don't like allografts here. But that's essentially what the posterior approach is. It's relatively straightforward. You can see in the x-ray here, there's a picture of an x-ray, that this is the hardware that they're doing. And they may actually kind of try to reposition the vertebrae so they're more straight, so that they're not as much of a shift in the vertebrae if they have some sort of spondylolisthesis issue, and then put the screws and the rods in just like that. The anterior approach is done when there's a lot more damage to the area, or when they're really worried about trying to get the alignment correct. The hard part about an anterior approach is that they do have to go through the stomach. So they have to put an incision through the abdomen and come through that way. And so they usually have to have a thoracic surgeon in the room as well. So the thoracic surgeon is the one who actually moves the organs out of the way, to then allow for the hardware to be put into the vertebrae. What's nice about this is that because we're coming from the anterior side, we don't have as much muscle or nerve damage possibilities, but again, you have to go through the stomach, so that makes it very difficult, and there tend to be more abdominal side effects with this particular surgery. A combined approach means just that. It's what they call kind of like a circumferential fusion. So they're actually doing the fusion from the front and the back. So again, if this is a very, very significant problem, then they may end up doing a circumferential fusion. So they're doing anterior and posterior approach. So let's take a look at the surgery here.
A posterior lumbar interbody fusion is performed to remove a disc that is the source of back or leg pain and fuse spinal vertebrae with bone grafts. It's called a posterior procedure because the spine is approached through an incision on the back. Instrumentation is used to provide space for placing the grafts and to help stabilize the spine. An incision is made in the middle of the low back. The muscles are moved aside and the lamina portion of the vertebrae are exposed. Cutting instruments are used to remove the spinous process, portions of the lamina, and portions of the facet joints from the back of the vertebrae. Removing bone here allows the surgeon to see the disc and compressed spinal nerves. A grasping instrument is used to remove most of the intervertebral disc, which relieves pressure on the compressed spinal nerve, allowing it to return to the proper position. Next, the vertebrae are prepared for instrumentation. A sharp awl is used to make holes in the pedicles for inserting pedicle screws. Screws are placed through a metal plate and then into the pedicle holes, ending with the screw tips in the middle of the vertebral bodies. Screws and plates are placed on both sides of the spine. Two more pedicle screws are then placed through the metal plate and screwed into the lower vertebral body pedicles. To prepare for bone graft insertion, the disc space is spread apart by moving the vertebral bodies or applying pressure on the pedicle screws. The screws are tightened to hold the disc space in this open position. Two bone grafts are then placed between the vertebral bodies. The bone grafts allow for eventual fusion as bone grows beneath the vertebral bodies. In variations of this procedure, spacers, cages packed with graft material, or ground bone graft material may also be packed into the disc space to aid with the fusion. To provide stability to the spine while the fusion occurs, the lower screws are loosened and the vertebral bodies are squeezed together. The screws are tightened in the compressed position, which allows for a tight fit of the grafts in between the vertebral bodies. Small screws called blockers are placed on the pedicle screws to lock the screws to the metal plate. The incision is closed and dressed to complete the surgery. Patients will typically be hospitalized for 2 to 4 days and should avoid strenuous activity for 6 to 12 weeks.
Okay, so let's talk about complications. This is definitely, again, this is definitely a surgery where complications are somewhat common. Infection can happen just like with any other surgery. Fibrosis or just fibrotic tissue getting into the area and causing decreased mobility, which we already have, can also be a problem. But then reoperation is very common, and usually this happens because of what's called pseudoarthrosis, which is radicular pain, so radiating pain down the lower extremity that is occurring because the bone didn't heal. So if the bone didn't heal and we end up with irritability of nerve root again, then that can cause this pain. And so then they have to go back in and figure out if they need to add more bone somehow, or some sort of spacer material, or if they need to just do some other surgery. Discogenic pain can happen, again, at the same level or above or below the fusion itself. And then pain at the other joints that will be affected in the spine following the surgery. The biggest issue that we see, though, for all of these is SI joint dysfunction. So if you think about what's happening with the fusion, most of the time they're going to fuse L4 and L5. Sometimes they'll fuse above L4 or from L5 to S1. But regardless, you have to be able to get motion through your back following the fusion. And so we know that the sacrum still has the ability to move following a fusion. And unfortunately, what happens is the sacrum takes on too much movement. And if there isn't stability around the pelvis, but as well as good hip mobility, then we end up getting SI joint dysfunction. And that's, again, 50 to 60% of the pain that people feel as a complication after a lumbar fusion is because of SI joint dysfunction. So it's really, really important that you're thinking about areas above and below a fusion to make sure that you have good mobility of things like the hip, the thoracic spine, as well as good stability around areas like the sacrum. This is a huge issue. And when we're talking about the sacrum, you'll see there was an article in Physical Therapy Journal just this past November that talked about how we need to think about sacroiliac pain. And I don't have this translated into Chinese for you guys because it is some relatively new research. But when we're talking about this, I think just being able to say to the patient, this pain is because we need to have good stability of the SI joint is probably fine. You don't need to say that they're unstable. You don't need to say that something is weak. You need to be careful with the words that you use. But what you can say is we need to make sure that the area around your SI joint is strong, because we don't want them to consider the idea that they need to stop moving because of some sort of pathology that's happened in their SI joint. Nothing has changed in their SI joint. The SI joint hasn't been injured. It's just not moving the same way that it was before the fusion. And so that's what you have to say. And so we want to encourage movement. And we also want people to understand that the sacrum, the SI joint, the pelvis with the sacrum, is inherently a very strong joint, and it can be strong for them. We just need to allow for the muscles around it to help with stability. And we also need to think about things like the hip and the knee. And so even though this has been a lumbar surgery, making sure, as I said earlier, that the hip is moving really well, that the knee is nice and controlled in their movements, and the fact that movement is good is really, really, really an important part of our rehab for these patients. So if we get to see them preoperatively, which we never do, then we want to spend time on patient education for this type of information. And you don't have to say, okay, you know what, you're likely to get an SI joint problem after the surgery. Of course, we don't talk about that, but we say that it's really important after surgery that we're thinking about what's going on with the pelvis, making sure that our hips are moving really well, and starting to talk about body mechanics, things like that. If they can perform some sort of cardiovascular activity without significant pain, like swimming and water aerobics tend to be really good because it unloads the back. But even if they can just do walking, that before the surgery, that's going to be helpful. And then we definitely want to allow for pain control because these people tend to be in a lot of pain. They need to understand that following surgery, they need to avoid any bending, lifting, or twisting. And when I say any, I mean there's going to be some bending because they have to get out of a chair. But the lifting and twisting for the first 6 weeks, it's really, really important that they're not performing those movements. They want to avoid lifting any more than 10 kilograms for 12 weeks. And then we want to make sure they understand how to do transfers and wound care following surgery. So again, it's all the same kind of patient education stuff that we would love to be able to do with all of our patients before a surgery. So fusions, we're starting with phase 1 at weeks 0 to 2, but there are definitely a lot of surgeons out there who will just tell a patient to go home and basically just move gently. So they don't tell them to lay in bed for 6 weeks, but they tell them to move gently for 6 weeks and not start rehab until after 6 weeks. And the research would say that there's not huge differences in outcomes between those two groups. So you may be seeing patients within the first 2 weeks after a fusion. We kind of hope that you do, but you don't have to. If they're in bed and hopefully they've been given kind of basic movement instruction, they're not just laying in bed for the first 4 to 6 weeks, that's okay. Our first phase goals, you'll notice a lot of these sound similar over and over again. You want to control inflammation and pain. You want to protect where the surgical site is. And then we are going to do movement. So we need to make sure that they understand how to do things like get up out of a chair or roll in bed. We also want to the patient to demonstrate no evidence of fear avoidance. So fear avoidance means that they're choosing not to move because of pain. And so, again, there's a lot of psychology behind these patients and their history of pain. And so we want to start very early with education related to allowing for movement that's the appropriate kind of movement. So that cognitive behavioral therapy education becomes a big part of our treatment. They also should be wearing a brace, and we recommend this thoracic lumbar sacral orthosis, or this type of brace that you see in the picture, just because it allows for a little bit more stability, but then it allows for the upper body to feel like it can move. So if you're just doing the back brace, oftentimes it doesn't allow for the same amount of stability. So during those first couple weeks, definitely want to be using the brace. And then we also want to teach the patient neutral spine. So again, trying to hold the spine in a relatively neutral position, starting to teach them how to turn on the muscles around the spine, the multifidi, transverse abdominis. And then we're giving them lower extremity bed exercises. Kind of boring stuff, but if they've had symptoms for many, many months, and this is the first time that maybe they don't have as much nerve pain or whatever in their lower extremities, then we definitely want to start increasing the strength in their lower extremities. So these are people that often have been experiencing symptoms for a very long period of time. And our rehab initially is going to be really just helping them start to use their lower extremities in a normal way. And that might be on the table, that might be in standing with a brace. And so during this phase, we really just want them to be able to do basic things like go to the bathroom. They need to learn how to get the brace on and off by themselves, because they should be wearing that brace when they're doing weight-bearing things, and then be able to perform bed mobility as much as they can, again, with the right posture without allowing for twisting through the low back. So second phase is usually from week 3 to 6. And it's during this time that we're really focused on activating multifidi and transverse abdominis, teaching them how to do that, allowing for more movement through the pelvis, and then starting to, while they're contracting those muscles, starting to teach them how to move their arms and legs with control of the multifidi and the transverse abdominis. And there's a good amount of research out there that talks about the fact that these patients, especially those who have had a long history of injury to their low back, they actually lose the ability to control multifidi muscles. So especially at those levels of injury, they can't really turn on the muscles correctly. And so we do have to retrain them to learn how to turn on those muscles, just like we talked about retraining patients after different kinds of knee surgeries, how to use their quad again. And when we talk about ACL, it's going to be the same thing, teaching them how to do something that their brain was working just fine before, and now we just have to retrain them a little bit. As I said earlier, we also want to really make sure that the hip mobility is good. So we're spending a good amount of our treatment time on hip mobility and making sure that that is that their rotation of the hip extension, hip flexion are all good. And we're educating them on the cognitive stuff. So making sure that they are showing us that they are not fearful of movement. We are also helping them understand that their movement patterns might have changed over the last years. And so we are starting to show them correct movement patterns. We also are lifting really just up to about 2.5 kilograms or 5 pounds. And we want them to walk and walk and walk and walk. And we're encouraging walking a lot, just like we did with our patients who have had any type of surgery for the disc. So specific treatment, you can do a little bit of soft tissue work for these patients and modalities for pain control, but you want to be careful because, again, we want them to sort of move past their focus on pain. So it's not a huge part of the treatment. Instead, we're starting to do more dynamic lumbar stabilization exercises, things like squats and lunges. The bike is fine as long as we're not putting them into too much flexion. And then we're spending a lot of time working on hip stretching and some stretches for the lower extremities. So to progress out of phase 2, we want them to be able to perform ADLs. It's really important that the exercise program that you've given them, as well as just basic ADLs, are performed without pain and with good body mechanics. So it's all about body mechanics during this phase. They should be able to show you that they can keep certain muscles turned on when it's appropriate and turned off when it isn't appropriate. So past week 6, up until about 4 months, we're into the phase where we're doing a lot more active activities. And it's really important that they understand that those active activities are okay. They should be automatically turning on these core muscles by the end of this phase during activities. So you should be able to palpate transverse abdominis, multifidi with the activities that you're doing, and they shouldn't have to think about turning those muscles on. They also should have some sort of aerobic exercise program. Again, walking is fine if they're an older person. And they should be able to perform forward bending by this point and do so with confidence. So normal bending, even through their low back. By the end of 4 months, they should be confident with doing that. And this is a big thing. Again, this is a big cognitive behavioral problem with these patients, is that they're scared of doing that motion because they've been told for many, many years, maybe months or years, that that's not an appropriate movement for them to do. So we also would like, by the end of phase 3, for them to start thinking about return to sport. And so we're starting to simulate, some of the types of movements that would be appropriate for return to sport. And I just have added this slide here from 2015 that kind of goes through this idea of, as they go through the phases, from on the left it talks about patient education. And so in the first couple of weeks, the first 3 weeks, you'll notice that patient education is just talking about how exercise is important and how we can manage pain. And then the topics start to increase to things like, how are we feeling about our pain? And then you'll notice the last couple of weeks out of the 10 weeks, we're really kind of making sure that their thoughts and behaviors are appropriate. And the big thing that I want you to get out of this is actually what's on the right-hand side, and this idea of peer support. And so what they found with a lot of these patients who have been dealing with low back pain for a long time is that not only do we want family support, which we always do, but we also want peer support. So having sort of support groups, maybe that have had low back pain, that can speak to each other about their experiences, having other medical professionals who can talk about kind of what to expect, and just having that support is really, really, really important because depression, unfortunately, is a very common diagnosis with these patients. And that obviously is going to lead to poorer outcome if the patient is being diagnosed with depression. And so providing them with opportunities for our own patient education during rehab, but also social opportunities with the people around them, and really encouraging that for these patients is a big part of what we should be doing through our rehab. So past the education, back specifically to treatments, this is where we're getting into things like planks and side planks and slight rotational movements with some basic resistance, but not huge amounts of rotation. We're also going to work on things like sit to stand and start doing a little bit more lifting, and then really spending a lot of time on aerobic exercise. And so to move out of this third phase, they really should be able to start doing sport activities, maybe not full-on sports, but some of the sport movements they want to do with a good neutral spine position and reports of no pain. They also should have confidence with that forward bending. It's really important that they can mentally do that and feel comfortable with it, and then feel very confident with some sort of aerobic and strength training program. So after 16 weeks is when we do our sport-specific training, and it's at this point that our goals are really focused on getting them back to sports. And there's no sports that wouldn't be allowed. There isn't anything in the literature that says that they can't be doing it. So whatever the patient really wants to get back to is fine. And it's after this 4-month period that we really should be planning for them to get back to sports. Some of these patients do have to return to lifting and carrying and pushing and pulling and things like that at work. And so this is when we would start that work conditioning or work hardening type of program as well. This last little slide here just gives us the research on the treatments. This is coming from 2017, and I do have the full reference in our select references list. And what you see here is this is the graded evidence for different types of treatment post-fusion. So you'll see that there's a grade B for cardiovascular exercise. So that's a pretty good recommendation that these patients should be performing cardiovascular exercise. There isn't good recommendations for things like soft tissue mobilization or even nerve mobilization. There just isn't enough evidence to show that nerve mobilization is helpful. But I will tell you that if they're still having nerve symptoms, usually doing nerve mobilization as treatment can provide at least temporary relief to those nerve symptoms. Motor control and strengthening, you'll see, has a grade B recommendation. So again, it's pretty good. So we definitely want to be working on motor control with our patients. Joint mobilization, not so much good research. Patient education has a grade A. So very good research to say that we want to make sure that there's good communication between us and those patients, looking out for any cognitive behavioral issues or fear avoidance issues, and making sure that we're addressing those fear avoidance issues as much as possible. There's grade B recommendations for how long you should do it and when you should do it. And basically the walking program, doing that immediately following surgery, is very important. And then you'll see there's only grade C recommendations for the need for rehab basically immediately after surgery, as well as the relationships, the rehabilitation relationships to outcomes. So we don't really know, but there's a grade B recommendation for psychosocial consideration. So again, considering this idea that these people need to have good psychosocial backgrounds, options. They need to have family support. They need to have friend support, and maybe even other patients to help them through this process. So that's spinal fusion. You will see a lot of patients, I think, in your career that are coming after spinal fusion. And again, don't get discouraged too much if their outcomes aren't amazing, because there's a lot of cognitive behavioral stuff related to it. But definitely a lot of these patients also get better and will tell you immediately after surgery that their significant nerve symptoms that they've had in their legs for years usually are just much better. So you can have some really good outcomes with these patients as well.